Chapter 25 in TIMBY Med-Surg, Caring for Clients with Disorders of Coronary and Peripheral Blood Vessels. Distinguish between arteriosclerosis and atherosclerosis. List risk factors associated with coronary artery disease and discuss which can be modified or changed. Describe the symptoms, diagnosis, treatment, and nursing management of coronary artery disease. Discuss the symptoms, diagnosis, treatment, and nursing management of a myocardial infarction. Discuss the symptoms, diagnosis, treatment, and nursing management of peripheral vascular disease, such as peripheral artery diseases, Raynaud's, thrombosis, phlebothrombosis, embolism, and venous insufficiency. Discuss the symptoms, diagnosis, and treatment of varicose veins. Describe nursing management of clients undergoing surgery for varicose veins, and discuss the symptoms, diagnosis, treatment, and nursing management of clients with an aortic aneurysm. Cardiovascular disease is the leading cause of death in the United States. Occlusive disorders, or blocking disorders of the coronary arteries, are resulting complications and largely responsible for cardiac death. Occlusive disorders of peripheral blood vessels can also contribute to morbidity and mortality. The most common causes of occlusive vascular disease are arteriosclerosis, atherosclerosis, clot formation, and vascular spasm. Venous insufficiency and valvular incompetence also foster peripheral vascular disorders. Arteriosclerosis refers to the loss of elasticity or hardening of the arteries that accompanies the aging process. As cells in arterial tissue layers degenerate with age, calcium is deposited in the cytoplasm. The calcium causes the arteries to lose elasticity. As the left ventricle contracts, sending oxygenated blood from the heart, the rigid arterial vessels fail to stretch. The potential result is a reduced volume of oxygenated blood delivered to organs such as the heart, brain, kidneys, and extremities. The incidence of arteriosclerosis and other vascular disorders increases with age. General physiologic changes of aging predispose clients to vascular occlusive disease, especially as a result of atherosclerotic plaque formation. In addition, atherosclerosis is the most common cause of peripheral arterial problems in the older adult. Atherosclerosis is a condition in which the lumen of the arteries fill with fatty deposits called plaque. The plaque is chiefly composed of cholesterol, a fatty lipid substance. Atherosclerosis is a more modifiable contributor than arteriosclerosis to vascular disease. Athero, remember, means fat, atherosclerosis. Therefore, it is a focus of attention and research into the mechanisms that contribute to plaque formation and its reduction to decrease vascular disease. Hyperlipidemia, or high levels of blood fat, trigger atherosclerosis changes. Factors such as gender, heredity, diet, diseases such as metabolic syndrome, and inactivity individually or collectively contribute to hyperlipidemia. For example, some clients are genetically predisposed to produce cells with reduced numbers of receptors for binding with cholesterol, so they're more likely to develop high lipid levels. Clients who consume a high fat diet may saturate all available cholesterol receptors, which also results in hyperlipidemia. Obese people with metabolic syndrome who are prone to diabetes tend to have lower levels of leptin, leptin, which regulates energy metabolism, and adenopectin, a protein with anti-inflammatory effects. Above normal cholesterol levels also have been linked to a byproduct of methionine, an amino acid present in meat called homocysteine. High levels of homocysteine are also implicated in thickening, narrowing, and scarring of arterial walls. Infection. A current hypothesis is that atherosclerosis is linked to prior infections with chlamydia pneumonia, a bacterium that commonly causes respiratory infections. Research has shown that C. chlamydia pneumonia can infect smooth muscle and endothelial walls of arterial cells. So some evidence suggests that C. pneumonia either accelerates the atherosclerotic process or destabilizes one that already exists, leading to an area of local inflammation. Scientists support their hypothesis with the finding that C. pneumonia has been cultured from atheroma, which is a fatty mass called atheroma in the arterial wall. Furthermore, results of blood tests such as highly sensitive C-reactive protein levels and white blood cell counts, which reflect inflammation and infection, are elevated among clients hospitalized for coronary events. An elevated high-sensitivity C-reactive protein, also called ultrasensitive CRP, recently has been added as a predictive cardiac risk factor, especially for women. Recently conducted large clinical trials support the C. pneumonia hypothesis and also suggest a connection between atheromatous plaque formation and other infectious microorganisms such as H. pylori, herpes simplex virus, and cytomegalovirus. However, research has not shown that antibiotic therapy plays a significant role in secondary prevention or improving long-term outcomes. Inflammation. Published information by Ballesteri and others in 2010 indicates a relationship between body fat and the production of inflammatory and thrombotic, which is clot-facilitating proteins. Researchers are finding that fatty tissue releases pro-inflammatory proteins called interleukin-6, tumor necrosis factor alpha, and a third protein known as plasminogen activator inhibitor 1. The first pair of proteins is believed to promote the buildup of atherosclerotic plaque in blood vessels. The third interferes with the body's ability to dissolve blood clots that form within the vessels. This information suggests that decreasing obesity and body fat stores via exercise, dietary modification, or developing drugs that target pro-inflammatory proteins may reduce risk factors for heart disease. Effects of multiple factors. Currently, it is safe to assume that multiple factors contribute to arteriovascular disease. A client with elevated lipid levels who also has other risk factors, such as cigarette smoking, stressful lifestyle, obesity, diabetes, hypertension, or a previous infection with C. pneumonia or other microorganisms, is predisposed to the accelerated accumulation of fatty plaque beneath the intimal layers of the artery. If you look at the figure in page 416 in TIMBY at the bottom, there's a cross-section of a normal artery, and the lumen or opening of the artery, that's the lumen, is fully patent or open. And then there's a B picture cross-section of an atherosclerotic artery. You can see the fat deposits in the lining of the lumen, and that's obstructing it with plaque. Currently, it is safe to assume that multiple factors contribute to the arteriovascular disease. When lipids accumulate, they are deposited under the endothelial cells of the tunica intima. The enlarging lesion elevates the endothelium of the artery wall and narrows the lumen. You can see the picture at the bottom of the page 25.1 on page 416. Again, atherosclerotic vessels cannot produce endothelial-derived relaxing factors, which impairs the ability of the artery to dilate. As the subendothelial atheroma enlarges, the intimal layer may split and expose the lesion. As blood flows through the vessels, the platelets become trapped in the roughened wall and initiate the clotting cascade. When the clot develops in a coronary artery, the resulting condition is called a coronary thrombosis. Occlusive disorders of the coronary blood vessels. Coronary occlusion, or blockage, is the closing of the coronary artery, which reduces or totally interrupts blood supply to the distal muscle area of the heart. So coronary artery disease precedes coronary occlusion, and if untreated leads to myocardial infarction, an MI, which is laypersons refer to as a heart attack. Symptoms usually do not occur until at least 60% of the arterial lumen is blocked or occluded. Coronary artery disease refers to arteriosclerotic and atherosclerotic changes in the coronary arteries supplying the heart. It may not be diagnosed until clients are in late middle age or older, but the vascular changes most likely begin earlier. Although coronary artery disease occurs 10 to 15 years earlier in men than women, the incidence rises in postmenopausal women and becomes similar to that in men after that. Women with a family history of cardiac disease show symptoms 7 years earlier than women with no family history. In a presentation of the American Heart Association scientific session in Orlando, Florida, William Herzog, a cardiologist on staff at Johns Hopkins Hospital, reported that women who smoke are symptomatic 9 years earlier than female non-smokers and 4 years earlier than male smokers, suggesting that women who smoke have a greater gender susceptibility to coronary artery disease. Coronary artery disease is the most common cause of death in adults older than 65 years. Pathophys and etiology. Coronary artery disease results from many factors rather than a single cause. Several inherited and behavioral risk factors contribute to the development of coronary artery disease. At rest, ample blood flow may be maintained despite considerable coronary artery disease. The condition may go unrecognized, particularly among those with a sedentary lifestyle. During situations that increase myocardial oxygen demand, such as exercise, emotional stress, etc., the compromised coronary arteries cannot adequately oxygenate the myocardium. When myocardial tissue becomes ischemic or deprived of oxygen, clinical manifestations of CAD, such as angina pectoris, which is chest pain from the heart, occur. Death of heart muscle does not accompany angina. Assessment findings, signs and symptoms. In mild coronary artery disease, clients are symptomatic or complain of fatigue. The classic symptom is chest pain or discomfort during activity or stress. Such pain or discomfort typically is manifested as sudden pain or pressure that may be centered over the heart or under the sternum, which is substernal. Over the heart, it's called precordial. Under the sternum is called substernal. The pain may radiate to the shoulders and arms, especially on the left side, or to the jaw, neck, or teeth. Some clients, especially women, experience more atypical symptoms such as nausea, fatigue, and dizziness, which are often overlooked as significant for heart disease and consequently go misdiagnosed. Some describe discomfort other than pain, such as indigestion or a burning, squeezing, or crushing tightness in the upper chest or throat. The American Heart Association now suggests the term acute coronary syndrome to describe any group of clinical symptoms compatible with acute myocardial ischemia, which is impaired oxygenation. If you look at page 417 in your book, risk factors for coronary artery disease, inherited risk factors are being male, having diabetes, increased lipid levels, genetic predisposition, and hypertension. Could all be inherited risk factors. Behavioral risk factors are smoking, sedentary lifestyle, obesity, competitive, aggressive personality, and a high-fat diet. In mild CAD, clients are asymptomatic or complain of fatigue. Again, in the classical symptom is chest pain during activity or stress. Women may have nausea, fatigue, and dizziness, which is often overlooked and misdiagnosed. Some clients show signs suggesting hyperlipidemia. They may be obese and hypertensive. An obese person with an apple-shaped body carries most weight in the abdomen, is at higher risk for CAD than one with pear-shaped body, which carries most weight below the hips. The pulse may be high at rest and become irregular with exercise. An opaque white ring about the periphery of the cornea in the eye, called arcus cinereus, results from a deposit of fat granules but may be apparent only in older adults. Xanthelasma is a raised yellow plaque on the side of the upper and lower eyelids, suggests lipid accumulation. Although research is ongoing, some cardiologists indicate a relationship between a diagonal crease in the earlobe and the risk for CAD, which you can see the pictures of the xanthelasma, which are the yellow plaques, figure 25.3 on page 418, and you can also see the bilateral diagonal earlobe crease on page 418 again, figure 25.5. Diagnostic findings. Diagnosis of CAD is a composite of lipid profile studies and electron beam computed tomography, as well as exercise, electrocardiography, cardiac cath, and arteriography, all of which are discussed later. EKG or stress testing may result ST segment depression, arrhythmias, or exercise-induced hypertension. A nuclear stress test using a radionuclide such as thallium may be injected intravenously during and a few hours after exercise electrocardiography, followed by a heart scan. Narrowing of one or more arteries in the coronary arteries is documented during coronary arteriography. Types of angina, page 25.1, page 418. Stable angina, the causes are 75% coronary blockage that accompanies exertion, and the person gets elevated heart rate or blood pressure, and also has pain with after eating or during eating a large meal. Unstable angina is progressive worsening of stable angina with more than 90% coronary blockage or occlusion. Variant angina, which is arterial spasm in normal or diseased coronary arteries. And microvascular angina, which is called cardiac syndrome X, is constriction of myocardial capillaries too small for standard cardiac tests to detect. So with stable angina, the symptoms are chest pain that lasts 15 minutes or less and may radiate, which means go to different places in the chest or the abdomen or the anterior part of the body. Similar pain severity, frequency, and duration with each episode. The treatment is rest, sublingual nitrates, antihypertensives, and lifestyle changes. For unstable angina, again, this is progressive worsening of stable with more than 90% coronary occlusion. Symptoms are chest pain of increased frequency, severity, and duration, poorly relieved by rest or nitrates. This client is at risk of myocardial infarction within 18 months of angina's onset. The treatment is sedation, IV nitro, oxygen, nitro means nitroglycerin, oxygen, antihypertensives, anticoagulant or antiplatelet therapy, and revascularization procedures. Variant angina, which is arterial spasm in normal or diseased coronary arteries. They have chest pain that occurs at rest, usually between 12 and 8 a.m. It's sporadic over 3 to 6 months and diminishes over time. The EKG shows ST elevation rather than depression. Nitrates or calcium channel blockers are used for treatment. The microvascular angina, which is the tiny capillaries too small to detect. The signs are prolonged chest pain that accompanies exercise and is not always relieved by medicine. And the treatment is heart-healthy habits and trials with medications like a nitrate, a beta blocker, or a calcium channel blocker. Diagnostic findings. Diagnosis of CAD is a composite of lipid profile studies and electron beam tomography, as well as exercise, EKG, cardiac cath, and arteriography, all of which are discussed later. A lipid profile study, a group of tests that measure various blood fats, is done. It is one indicator of a person's risk for cardiac and vascular disease. A lipid profile generally consists of measuring total serum cholesterol, low-density lipoproteins called LDLs, cholesterol, high-density lipoproteins called HDLs, cholesterol, and triglycerides. Cardiac risks increase when the level of total serum cholesterol is elevated. Another risk factor is an elevation of triglycerides, which are chains of fatty acids. Proteins transport lipids, which are cholesterol, in the blood. Low-density lipoprotein, LDL, has a lower ratio of protein to cholesterol. High-density lipoprotein, HDL, is just the opposite. It has a higher ratio of protein to cholesterol. In clients with coronary artery disease, the level of LDL, which sometimes is referred to as bad cholesterol because it sticks to arteries, exceeds recommended amounts. The level of HDL, called the good cholesterol because it carries cholesterol to the liver for removal, is lower than desirable. Cardiac risk can be estimated by dividing the total serum cholesterol level by the HDL level. A result greater than 5 suggests the potential for CAD. Depending on an assessment of risk factors, treatment for hyperlipidemia may begin when the LDL level ranges between 100 mg per dl and 130 mg per dl, with the goal being a level below 100 milligrams per dl. So again, you have low-density lipoproteins and you have high-density lipoproteins. So the low-density lipoproteins is the bad cholesterol. The high-density lipoproteins is considered the good cholesterol. Electron beam tomography, EBCT, is a radiologic test that produces X-rays of the coronary arteries using an electron beam. This is non-invasive and can scan the heart in 1/20th of a second using 10 times less exposure to radiation than a CT machine. EBCT also produces much clearer images for diagnostic purposes. The advantages is that it can detect and quantify calcium plaque in the coronary arteries before clients who do not fit the usual cardiac profile are symptomatic. There is a high degree of correlation between the amount of calcium plaque identified by the EBCT and the future risk of MI, which is the heart attack. If the test results demonstrate the existence of heart disease, treatment interventions are started earlier than with conventional diagnostic regimens. The efficacy of treatment or the need to modify it is evaluated by repeating the test at 1 year or longer intervals. So your values for total cholesterol, desirable value is less than 200 mgs per dl. Low density lipoproteins, LDLs, optimal is less than 100 mgs per dl. High density HDLs, less than 40 mgs per dl. Actually, 40 to 59 is acceptable, and 60 or more is optimal for HDLs, so greater than 60. And triglycerides, optimal would be less than 149, and that's some numbers that you should know. Electron beam computed tomography, we talked about briefly, is a test that produces X-rays of the coronary arteries. This test is that it can advantages that it can detect and quantify calcified plaque in the coronary arteries before clients are symptomatic, so that they can treat this. And there's a high degree of correlation between the amount of calcium plaque identified by the test and the future risk of MI. If the test results demonstrate the existence of heart disease, treatment interventions are instituted earlier than usual. So the efficacy of treatment or the need to modify it is evaluated by repeating the test at 1 year or longer intervals. Medical management. The first line of defense for managing CAD is lifestyle changes such as quitting smoking, weight loss, stress management, and exercise. Blood sugar is kept regulated. When these methods are inadequate, drug therapy and other non-invasive, non-surgical, or surgical interventions are used. Drug therapy includes medications that produce arterial vasodilation, such as nitrates, like nitroglycerin, isorbide, or called Isordil. Beta-adrenergic blockers, which decrease consumption of heart oxygen usage by reducing heart rate, are also used. Calcium channel blockers may be used as well, although research has shown that they may be less beneficial than beta-adrenergic blockers. Drugs such as angiotensin-converting enzyme inhibitors and diuretics, as well as stress management, are used to control hypertension. Niacin in pharmacological doses, not the dosage in multivitamins, helps increase HDLs and lower LDLs. Daily intake of food sources or supplements of folate or folic acid, vitamin B6, and vitamin B12 reduce homocysteine levels. However, evidence is not sufficient to recommend folate and other vitamin B supplements as a means to reduce CVD risk, according to the American Heart Association. Ubiquinone, also known as coenzyme CoQ10, is a nutraceutical dietary supplement that provides health benefits. CoQ10 is an antioxidant synthesized from food sources to produce mitochondrial ATP production in all cells, but especially in muscle tissue. The administration of cholesterol-lowering drugs like statins inhibits the formation of CoQ10. When depleted, those taking a statin may experience muscle pain. Supplementing 100 to 200 milligrams of CoQ10 daily while taking a statin medication is believed to decrease the incidence of muscle pain. Make sure you remember that and tell your patients, because a lot of people are not aware of that, and I don't think that the providers necessarily tell them about that. Sublingual nitroglycerin, if you need to use it, is placed under the tongue for acute relief of angina pectoris, which is chest pain. A transdermal nitroglycerin patch is for prevention of angina pectoris. Nitroglycerin transdermal patches are typically applied for 12 to 14 hours and then removed for the same amount of time. When removing a patch, close the adhesive edges together, preventing accidental exposure to others. Teach clients to dispose of patches away from children and pets. Older adults are more sensitive to the hypotensive effects of nitrates and calcium channel blockers, probably because of impaired venous valves, diminished baroreceptor reflex, and decreased vascular volume. These drugs need to be used with caution. Again, they can cause hypotension. And you can see on page 421, these are agents used to treat coronary artery disease and MI. You want to use Plavix or clopidogrel to prevent clots, thrombus prevention by inhibiting platelet aggregation and clotting. So again, clopidogrel, which is Plavix. Salicylates like aspirin and Ecotrin and ascriptin, or all aspirin, inhibit MI problems by inhibiting platelet aggregation again and clotting. So you're preventing emboli from forming. Calcium channel blockers relieve chest pain by dilating the arteries, improve myocardial blood supply. Diuretics are used, such as Lasix, to decrease the work of the heart by promoting excretion of sodium in water, so you're reducing the circulating blood volume. HMG CoA reductase inhibitors called statins. These are the ones that are given for high cholesterol. Atorvastatin, rosuvastatin, and simvastatin. They inhibit the manufacture of cholesterol, which increases the vessel's integrity following cardiac procedures. So again, it prevents the cholesterol from forming and in those vessels and blocking them. Assessing for orthostatic blood pressure changes following meals can help identify risk for postprandial hypotension. This is another situation. During digestion, blood flow diverts to the GI tract. Peripheral vascular valves closure may be sluggish in older adults, allowing gravity to pull blood volume to the lower legs, resulting in decreased cerebral blood flow. So it's going to cause dizziness and confusion and increased potential for falls. If weight loss, diet, and exercise are not successful in lowering elevated cholesterol and triglyceride levels, drugs may be used to prevent further plaque formation. Lipid-lowering drugs, which I just mentioned, HMG, CoA reductase inhibitors known as statins, and bile acid sequestrants may be prescribed. Fibric acid agents, such as Lopid, are used to decrease triglycerides. Some physicians advise taking 1 aspirin or low-dose aspirin, 81 milligrams a day, to prevent thrombi from developing. Because soy products are classified as phytoestrogens, plant sources of estrogen, some clients are increasing consumption of soy as a cardioprotective strategy, although evidence of benefits from soy protein is minimal. Reverse lipid transport. Reverse lipid transport is a new form of treatment. Researchers have developed synthetic HDL, an investigative drug using recombinant DNA techniques from a variant protein obtained from the genes of a group of people living in Italy. These people with the variant form of apolipoprotein A1, a component of HDL, have a low rate of coronary vascular disease. Research participants in recent clinical trials demonstrated a rapid decrease of plaque in diseased arteries, suggesting that the substance has the potential to reverse CAD. And research continues in this area. Another approach is reverse lipid transport that is under study is HDL selective delipidation, a procedure in which plasma is withdrawn, processed in such a way as to modify the HDLs into super HDLs and reinfused into the client to reverse plaque formation. Enhanced external counter pulsation, EECP, may be used as an adjunct to drug therapy and lifestyle modifications. This is new, non-invasive, and non-surgical, and helps relieve chest pain from angina. It requires 1 to 2 hour sessions in the doctor's office 5 days a week for 7 weeks. During EECP, the client puts on a pressure suit with pneumatic cuffs at the upper and lower thighs and calves. The cuffs are connected to a cardiac monitor and are sequentially inflated in a wave-like fashion from the calves to the upper thighs during ventricular diastole, which is the resting period. The cuff pulsation, which has been compared to a strong hug, moves blood toward the heart. Because the coronary arteries fill during ventricular diastole when the aortic valve closes, cuff inflation increases perfusion of the coronary arteries with oxygenated blood. When the cuffs deflate during ventricular systole or contraction, the left ventricle's work is reduced because there is less resistance. A number of randomized control studies have found that EECP promotes the development of collateral circulation, which is accessory or additional vascular pathways for blood, through angiogenesis, which is the formation of new blood vessels. It also reduces inflammatory activity and improves endothelial function. This is as of 2015 and studies in 2012. Advantages of EECP is that it reduces the frequency of chest pain from angina and improves exercise tolerance. Disadvantages is that it's time-consuming and very few physicians offer or refer clients for it. Some believe that lack of interest from physicians is related to the fact that third-party payers can better reimburse them for other less time-consuming treatment modalities such as drugs, etc. Surgical management or invasive perfusion techniques. Nursing management. The nurse assesses the characteristics of chest pain and administers prescribed drugs that dilate the coronary arteries or reduce the work of the heart. You want to encourage rest and administer oxygen to improve the available oxygen supply to the heart. If drugs, rest, and oxygen do not relieve the pain, the nurse notifies the provider. The nurse helps clients learn how to reduce modifiable CAD risk factors, which can improve not only cardiac health, but overall well-being. You need to explain that balancing caloric intake with physical activity to achieve or maintain healthy body weight can significantly reduce risk. The nurse arranges a consultation with a dietitian and provides written material about a heart-healthy diet. Also, the nurse urges clients to stop smoking and gives them resources for programs and discusses medicines that can help with the cessation of smoking. The nurse teaches about the administration and side effects of anti-anginal drugs. You want to look at client and family teaching in table 25.2 in the book. He or she also emphasizes that severe unrelieved chest pain indicates a need to be examined by a physician without delay. The nurse advises the client to report changes in the usual pattern of chest pain, such as increased frequency or severity or occurrence with rest or during sleep. The nurse informs clients about diagnostic tests or treatment procedures. The nurse who prepares the client for invasive non-surgical procedures performed with a percutaneous catheter, cleanses and removes hair from the skin insertion sites, one for the coronary catheter and the other for the arterial line through which the blood pressure will be directly monitored. The nurse withholds anticoagulant therapy before the procedure to decrease the chance for hemorrhage. The nurse monitors all vascular sites for bleeding after a procedure and assesses distal pulses. The nurse also observes mental status because cerebral emboli can occur. He or she monitors urine output and administers analgesics for discomfort. Any of the following data are reported immediately: severe chest pain, abnormal heart rate or rhythm, mental confusion or loss of consciousness, low hypotension, blood pressure, urine output of less than 30 to 50 mLs per hour, or a cold, pulseless extremity. Question: a 55-year-old client has been diagnosed with coronary artery disease. The nurse is teaching the client nutritional aspects of a low cholesterol diet. Which statement made by the client indicates understanding of the diet? Broiled chicken with the skin removed contains no cholesterol. Eat fish rather than red meat because it contains no cholesterol. It is permissible to use polyunsaturated oils to fry food. Egg whites do not contain cholesterol. So, which statement made by the client indicates understanding of the diet? The answer is egg whites do not contain cholesterol. Egg yolks contain cholesterol. Egg whites do not. And remember, there are some fish that do contain high amounts of cholesterol and fat. Myocardial infarction. An infarct is an area of tissue that dies, necrosis, from inadequate oxygenation. An MI or heart attack occurs when there is prolonged total occlusion of coronary arterial blood flow. The larger the necrotic area, the more serious the damage. An infarct that extends through the full thickness of the myocardial wall is called a transmural infarction or Q-wave MI. A partial thickness infarct is called a subendocardial infarction or a non-Q-wave MI. Each coronary artery supplies oxygenated blood to a different area of the heart. The location of the infarction depends on the area where the blood supply to the myocardium is interrupted by the respective coronary artery that's blocked. Pathophys and etiology. The most common cause of MI is coronary thrombosis, the consequence of a blood clot located within a coronary artery. Thrombosis usually is secondary to arteriosclerotic and atherosclerotic changes. Arterial spasms also may cause an MI. Once an area of the myocardium has been damaged and destroyed, the cells in that area lose their special functions of automaticity, excitability, conductivity, contractility, and rhythm. Thus, arrhythmias and heart failure are common consequences. Injury to the myocardium triggers the inflammatory response. Pro-inflammatory chemicals disrupt the permeability of cell membranes. The damaged cells release serum cardiac markers called intracellular enzymes and electrolytes into the extracellular fluid. Loss of intracellular potassium and accumulation of lactic acid from anaerobic cellular metabolism affects depolarization and repolarization of myocardial cells. Dangerous arrhythmias can develop during this time because the affected areas are electrically unstable. The infarction process can take up to 6 hours. There are 3 zones of tissue damage. The first zone consists of a central area of necrotic or dead myocardial cells. The second zone of injured cells, which may live if blood supply to the area is restored, surrounds the first zone. The third zone is the ischemic area that will probably survive. If you look at page 427 in Timby, chapter 25, figure 2510, there are zones of myocardial infarction based on the artery that became occluded. It's showing you the different zones based on the artery that was occluded or blocked. Thrombolytic drugs called clot busters are given during the 6-hour window of opportunity to reestablish blood flow and save as much myocardial tissue as possible. Leukocytosis and slightly elevated blood temperature follows in 3 to 7 days. New capillaries begin to grow to establish collateral circulation to the infarcted area. However, it takes 2 to 3 weeks before such flow is significant. A cardiac patch of collagen fibers begins to form within the first 2 weeks of the infarct, but it takes as long as 3 months for the scar to grow firm. The scar tissue is less effective than the heart muscle it's replacing. It does not stretch and contract like the original tissue. Lack of resiliency impairs the heart's ability to pump effectively. Consequently, cardiomyopathy and heart failure are always lifelong potential complications. Complications. Arrhythmias, sometimes called a dysrhythmia, refers to changes from the normal sequence of cardiac impulses resulting in an erratic, in other words, abnormal, irregular heart rhythm, or rates that are too fast or slow. Any number of arrhythmias, you can see chapter 26 for more information, may occur during the acute phase of the heart attack. More than 50% of death from heart attack or MI occur within 72 hours for this reason. Some abnormal rhythms can be fatal within a few minutes. Early detection and treatment reduces the fatality rate. If a client experiences cardiac arrest, which is asystole, neurologic damage may occur. Neurologic outcomes can be improved by preventing hyperthermia. The American Heart Association indicates that the maintaining an induced hypothermic state, which is cold, for 12 to 24 hours after resuscitation reduces the brain's oxygen requirements. The best method for facilitating hypothermia is the application of several cooling gel pads at strategic locations on the body. The pads are connected to a temperature management console. In rural areas where this type of equipment is unavailable, hypothermia can be induced using an external hypothermia blanket or ice packs or administering cold saline through a peripheral intravenous catheter or endovascular cooling catheter. Cardiogenic shock, which has a high mortality rate, occurs when 40% of the left ventricle has lost the ability to pump effectively. The onset may be sudden, or the condition may develop over hours or days. The sooner shock is detected, which is done by monitoring with a pulmonary artery catheter, and treatment is instituted, the better the client's chances of survival. This complication has been successfully treated with medications, ventricular assist devices, and an intra-aortic balloon pump. Ventricular rupture. Ventricular rupture occurs when a soft, necrotic area from a transmural or interventricular septal MI ruptures. Dyspnea, rapid right-sided heart failure, and shock result. Hemopericardium, which is blood in the pericardium, and cardiac tamponade follows. The prognosis is poor, although survival is possible. Ventricular aneurysm is bulging of the portion of the heart affected by the MI. This area of poorly contractile tissue predisposes the heart to failure. Blood trapped in the projection tends to form thrombi, which may be released into the arterial circulation, or the aneurysm may burst, resulting in hemorrhage and death. Arterial embolism. Clots can form in the cavity of the ventricular aneurysm, which are called mural thrombi, or tissue debris can break free. If clots enter the systemic arterial circulation, they may occlude a peripheral artery. Symptoms depend on the location of the affected artery. Arteriotomy, which is opening of an artery, and embolectomy, which is removal of an embolus, may be necessary. A client who has recently had an MI, however, is a poor surgical risk. Venous thrombosis arises mostly in the veins of the lower extremities and pelvis. The use of anti-embolism stockings and regular performance of foot and leg exercises help to prevent thrombus formation. Antiplatelet medications and anticoagulants are also prescribed. Pulmonary embolism. Most pulmonary emboli arise from venous thrombi in the lower extremities and pelvis. They may also arise from the right ventricle after an MI. The onset of a pulmonary embolism usually is sudden, with chest pain, dyspnea, and cyanosis being the first symptoms. The sputum may be tinged with blood. Treatment depends on the size of the infarcted area, the age and condition of the client, and the seriousness or extent of the MI damage. Pericarditis may be mild or severe. The mild form may not require treatment. If pericardial effusion develops, the client is observed closely for signs of cardiac tamponade. Pericardiocentesis is done to remove the excess fluid that actually is in the sac surrounding the heart. Mitral insufficiency. If the papillary muscles are involved in an MI and the mitral valve leaflets are compromised, mitral regurgitation may occur. In this condition, blood not only flows forward into the aorta, but backward into the left atrium through an incompetent mitral valve. Assessment findings. Signs and symptoms vary between men and women. Men typically experience sudden, severe chest pain, which usually is substernal and may radiate to the shoulder, arm, teeth, jaw, or throat. Women, more often than men, have more vague symptoms such as unexplained fatigue, abdominal pain, and shortness of breath, which often leads to misdiagnosis of women in emergency departments. Most clients are aware of the seriousness of their symptoms and are apprehensive. When chest pain is experienced, it is more severe and lasts longer than anginal pain. Some clients describe it as squeezing or crushing. Unlike anginal pain, rest and sublingual nitrates do not relieve MI pain. If untreated, it may last for several hours or 1 to 2 days. Finally, it becomes sore or achy before disappearing entirely. A few clients, such as older adults and diabetics, experience little or no pain and may never know that they had an MI until an EKG detects it weeks, months, or years later. Clients appear pale and diaphoretic. Diaphoretic is sweating profusely. They may experience nausea and vomiting or be hypotensive and faint. Pulse is rapid and weak and may be irregular. Signs of left-sided heart failure is dyspnea, cyanosis, and cough may appear if left ventricular pumping is sufficiently impaired. Symptoms of MI in older adults can include dyspnea, confusion, syncope, epigastric distress, nausea, heartburn, or indigestion. These symptoms may be unrecognized as significant by older adults, family members, or healthcare providers, thus causing a delay in treatment. Diagnostic findings. Serum enzymes and isoenzymes. Lab tests to diagnose MI include a series of serum cardiac markers, substances that are released by damaged myocardial cells during an infarct. When tissues and cells break down or damage or die, great quantities of certain enzymes are released into the bloodstream. Enzymes are complex proteins produced by living cells that function as catalyst substance capable of producing chemical changes without being changed themselves. An isoenzyme is one of several forms of the same enzyme that may exist in cells and is capable of being identified separately from others. The following serum cardiac markers are measured initially and every 8 hours for 24 hours to determine elevated levels. Myoglobin, a biomarker that rises in 2 to 3 hours after heart damage. Troponin and subunits known as troponin T and troponin I are enzymes in myocardial contractile tissue. Creatinine kinase, abbreviated CK, formerly creatinine phosphokinase, and its cardio-specific isoenzyme CK-MB. So now they call it CK. Lactate dehydrogenase, LDH, and isoenzymes in LDH1 and LDH2. Aspartate aminotransferase, which is abbreviated AST, formerly called serum glutamic oxaloacetic transaminase, SGOT. So now we have the new terms are the CK, creatinine kinase, the LDH, lactate dehydrogenase, isoenzymes LDH1 and LDH2, and then AST, which was formerly called serum glutamic oxaloacetic transaminase. Troponin is present only in myocardial tissue, so it is the gold standard for determining the heart damage in the early stages of an MI. The other enzymes can be elevated in response to cardiac or other damage. Troponin is TROPONIN. the other enzymes that can be elevated in response to cardiac or other organ damage. Therefore, the isoenzymes CK/MB, which is known as creatinine kinase now, LDH1 and LDH2 are elevated for their cardiac specificity. Miscellaneous lab and diagnostic tests, the WBC count, the white blood cell count, C-reactive protein, and erythrocyte sedimentation rate increase on about the third day following an MI because of the inflammatory response that the injured myocardial cells triggered. Blood glucose level may be elevated because of the body's response to a major stressor. After an MI, characteristic changes appear on the EKG within 2 to 12 hours. They may, however, take as long as 3 days to develop. These changes include T-wave inversions, ST segment elevations, and a Q-wave. Medical management treatment is directed to nursing assessment of an acute MI. You need to get the description of the pain, when it started, give a 0 to 10. Also, a pain description of where it travels, if it travels at all in the body. You need the vital signs. You need a cardiac rhythm. You need heart and lung sounds and peripheral pulses. Diagnosis, planning, and interventions. If there's acute pain, you need to, this is a review, you need to administer oxygen, nitroglycerin, and IV morphine sulfate. Risk for anxiety or fear related to perception of impending doom, meaning death. Explain procedures, promote rest, acknowledge grief, administer prescribed sedatives. And the evaluation of expected outcomes is that pain is reduced to a tolerable level, anxiety is reduced, and the client has self-reported tolerance of stressors. Question: which of the following interventions will the nurse anticipate implementing for a client with a diagnosis of an MI? A. Adjusting the bed to a Trendelenburg position. B. Maintaining prescription of complete bed rest for at least 5 days. C. Providing clear fluids throughout hospitalization. Or D. Administering a stool softener to prevent straining with bowel movement. The answer is D. Administering a stool softener to prevent straining with a bowel movement. This reduces the risk of constipation and straining, which may put a strain on damaged myocardium. Remember, the vasovagal response can definitely stop the heart and do more damage. Occlusive disorders of peripheral blood vessels. PVD, peripheral vascular disease, is a general term for disorders that affect blood vessels distant from the large central blood vessels supplying the heart or that circulate blood directly in and out of the heart. Peripheral vascular disease includes disorders that affect arteries or veins. Common peripheral vascular disorders which reduce blood flow by various mechanisms include peripheral artery disease, called PAD, Raynaud's disease, thrombosis, phlebothrombosis, and embolism. Many older adults have peripheral vascular disease, valvular insufficiency that is manifested in weak or absent pedal pulses, cold, clammy feet, thickened toenails, and shiny skin on the lower extremities. Discourage older adults from using electric heating devices. Burns are more likely to occur because of decreased temperature perception resulting from impaired circulation. Thermal underwear, socks, gloves, and blankets are alternatives to electric blankets and heating pads. Peripheral artery disease. More than 9 million people in the U.S. have PAD, a condition that affects primarily the blood vessels that supply oxygen to the lower limbs, which is the focus of this chapter, this discussion. The same pathologic process, however, can affect the carotid, renal, and mesenteric arteries as well. Men are more affected than women in the lower extremities. As the disorder worsens, some affected individuals may develop critical limb ischemia, a complication characterized by open sores or infections that do not resolve, becoming gangrenous and threaten the viability of the limb, making amputation necessary. Pathophys and etiology. When blood flow through arteries distal to the aortic arch become restricted, individuals experience manifestations of ischemia in the tissues where circulation is impaired. The primary cause is atherosclerosis, which, like its counterpart, CAD, is secondary to obesity, hypertension, hyperlipidemia, diabetes, chronic smoking, and in some cases, a family history of PAD or other atherosclerotic diseases. Increased blood level of homocysteine, an amino acid formed from protein-rich food containing methionine, is higher among those with PAD. Other than identifying it as a risk factor for PAD, however, the role of the high cysteine in this disease and the effect of controlling its level have not been sufficiently researched. Signs and symptoms. Clients with PAD experience intermittent claudication, or pain and cramping in the thigh, calf, or buttock muscles during activities such as walking or climbing stairs. The discomfort is relieved after resting for several minutes. One or both lower limbs feel cold to the touch. Upon exertion, many describe feeling numbness in the affected leg, accompanied by heaviness and fatigue. Some develop skin lesions that are slow to heal. Hair and toenail growth are slow. The skin over the legs appears red in a dependent position but returns to normal color in 1 minute when elevated. Pulses in the lower extremities are difficult to palpate. Men may experience erectile dysfunction. Diagnostic findings. The tentative diagnosis begins with taking a history of the client's symptoms and examining the lower extremities. Blood tests that reveal elevated total cholesterol, high LDL, above normal triglycerides, and increased homocysteine contribute to the diagnosis. One of the simplest tests involves measuring the ankle brachial index, a comparison of the systolic pressure in the brachial artery with that in the posterior tibial artery using a Doppler ultrasound at rest or after exercise. If you look at page 435, figure 2513, you can see how this is done. The severity of the disorder is determined by dividing the systolic blood pressure in the ankle by the systolic pressure in the arm. When the quotient or result of the division is 0.9 or less, the data supports a diagnosis of PAD. Clients may also undergo angiography using a CT scan or MRI. Invasive angiography using a contrast agent may be used to detect the specific location of blocked arteries or determine improvement after endovascular procedures. Medical and surgical management. Clients are encouraged to lose weight, exercise daily, and stop smoking. Diabetics must keep their blood sugar levels under control. Several classes of drugs, such as antihypertensive, lipid-lowering, antiplatelet, and antithrombotic medications, help to slow the progression of symptoms and reduce the risk of complications. Percutaneous and surgical revascularization procedures are performed when clients develop advanced disease. Nursing management. The nurse explains the reason for lifestyle changes in diet, exercise, and adhering to medications. The action, dosage, administration schedule, and side effects of each drug are explained, as well as any blood tests that are required for maintaining safety with these medicines. The nurse palpates and compares lower extremity peripheral pulses bilaterally. The skin on the extremities is assessed, and the nurse teaches the client to notify the doctor if cyanosis, skin lesions, or gangrene are detected. The nurse sets an example for daily skin and foot care, including washing and drying the feet well, applying moisturizing lotion, changing cotton socks daily, and wearing supportive shoes. Regular attention by a podiatrist is recommended for the thick nails that are difficult to trim, corns, calluses, or blisters that may form. The nurse stresses the danger of applying direct heat to the lower extremities and shows the client how to avoid positions that interfere with blood flow, such as crossing the legs at the knee. Besides the prescribed exercise regimen, the nurse recommends sedentary exercises such as extending the knees and ankle, pumping, and rotation to promote circulation, followed by periods of rest. Raynaud's disease. Raynaud's disease is characterized by periodic constriction of the arteries that supply the extremities. This is most common in young women. Raynaud's disease is characterized by brief spasms of the arteries and arterioles in the fingers, toes, nose, ears, or chin. The spasms last approximately 15 minutes and cause temporary ischemia, which is impaired oxygenation to the tissues. The vessels then dilate widely, apparently to compensate for restriction. Patchy areas of necrosis occur with prolonged ischemia. The underlying cause of Raynaud's is not entirely clear. In some clients, it seems idiopathic. no explainable reason. In others, it is secondary to connective tissue disorders such as scleroderma, systemic lupus, or rheumatoid arthritis. The anatomy of the arteries and arterioles is normal. One theory explaining the vasospasms is impaired release of prostaglandins, chemicals stored in cellular membranes. Some prostaglandins cause vasoconstrictions and others cause vasodilation. The type that accompanies an inflammatory response causes vasodilation. Assessments. Attacks are intermittent and of varying frequency, but are especially common after exposure to cold. When the condition occurs in the hands, they become cold, blanched, and wet with perspiration. Numbness and tingling also may occur. The client may note awkwardness and fumbling, especially when attempting fine movements. After the initial pallor, the hands, especially the fingers, become deeply cyanotic and begin to ache. The hallmark symptom of arterial insufficiency include ischemia, pain, and paresthesia. Placing the affected part in warm water or going to a warm area can relieve an attack. Eventually, the vasospasm is relieved and blood rushes to the affected part. The skin in the deprived area becomes flushed, swollen, and warm, and the person has a sensation of throbbing pain. In the early stages of the disease, the hands usually appear normal between attacks. The disease does not necessarily progress to cause severe disability. Symptoms often are mild and may even improve. When disease is severe and of long standing, cyanosis of the fingers persists between attacks and skin changes gradually develop. Painful ulcers and superficial gangrene may appear at the fingertips. The fingers are especially vulnerable to infection. Healing of even minor lesions is slow and uncertain. No specific laboratory studies can confirm Raynaud's disease. Diagnosis is made by a history of the symptoms and examination. Blood tests are ordered to confirm or rule out accompanying connective tissue disorders. Medical and surgical management. Treatment involves avoiding factors that precipitate attacks. Smoking is contraindicated because it causes vasoconstriction. Drug therapy with peripheral vasodilators such as vasodilan may be attempted, but results usually are less favorable. Other drugs such as Procardia are being used investigationally. An IV infusion of prostaglandin E may provide temporary relief. Sympathectomy, which is cutting peripheral sympathetic nerves, may be performed, but because of disappointing results, the procedure is performed less frequently than in the past. Gangrenous areas are amputated. Nursing management. Once an episode of pain occurs, there are several ways that can stop the attack. If warming the hands in water is impossible, the nurse encourages the client to imagine warming them in some way, such as holding them near a roaring fire. The mind can alter the physiology of blood flow. Another technique is to teach clients to imitate the exercise snow skiers use called the McIntyre maneuver. While standing, clients swing their arms behind and then in front of their bodies at a rate of about 180 times per minute. The swinging motion distributes blood to the distal areas of the fingers. Teaching for clients with Raynaud's disease and their family members is important. The nurse instructs clients to avoid situations that contribute to ischemic episodes, explaining that injuries may heal slowly. If clients smoke, they must stop because nicotine causes vasoconstriction and increases the frequency of the episodes. The nurse advises clients to wear wool socks and mittens during cold weather. Clients should avoid over-the-counter decongestants, cold remedies, and drugs for symptomatic relief of hay fever because of their vasoconstrictive qualities. The nurse advises clients to wear gloves, work gloves during household chores such as gardening and washing dishes to prevent accidental injury. Client teaching also includes information about how to perform nail care to avoid injury, such as soaking the hands or feet before trimming the nails straight across, and seeing a podiatrist for the treatment of corns or calluses. If sympathectomy is done, the nurse emphasizes that the areas of altered sympathetic stimuli no longer perspire and explain that applying cream to prevent excessive skin dryness may be helpful. Thrombosis, phlebothrombosis, and embolism. A thrombosis is a stationary clot. An emboli is traveling clots. Thrombosis is a state in which a thrombus has formed in a blood vessel. Thrombophlebitis is an inflammation of a vein with a clot or thrombus formation. Phlebothrombosis is the development of a clot within a vein without inflammation. Phlebothrombosis and thrombophlebitis have similar symptoms and treatment. An embolus is a moving mass or clot of particles, either solid or gas, in the bloodstream. Thrombosis in the venous system most often occurs in the lower extremities and usually is associated with disorders or circumstances that cause venous stasis, such as inactivity, immobility, or trauma to a blood vessel. Orthopedic surgical procedures increase the incidence of DVTs of the lower extremities. Atherosclerosis, endocarditis, pooling of blood in a ventricular aneurysm, and arrhythmias such as atrial fibrillation can precipitate arterial thrombosis and subsequent embolization. When a thrombus forms or an embolus reaches a blood vessel too small to permit its passage, blood flow is partly or totally occluded. Assessments, signs and symptoms. When an arterial clot is present, symptoms arise from ischemia due to the tissues that depend on the obstructed vessel for their oxygenated blood supply. With total occlusion, the extremity suddenly becomes white, cold, and extremely painful. Arterial pulsations are absent below the obstructed area. Numbness, tingling, or cramping may also be present, and surrounding blood vessels spasm. Loss of sensation and ability to move the part follows. Symptoms of shock frequently result if a large vessel is obstructed. When a small vessel is occluded, symptoms of ischemia such as pallor and coldness occur but are less severe. Unless blood flow is restored, gangrene develops. Clients with phlebothrombosis may have few, if any, symptoms because inflammation is absent. Signs and symptoms of DVT usually include mild fever and pain, swelling, and tenderness of the affected site. A thrombus, or I should say extremity. A thrombus may become a mobile embolus and lodge in a distal blood vessel, such as the pulmonary capillaries, causing symptoms related to the organ to which circulation has become impaired. Diagnostic findings. Arteriography or venography, also called phlebography, using a contrast dye, identifies the point of obstruction. Doppler ultrasound is used to detect abnormalities in peripheral blood flow. Plethysmography measures volume changes in the venous or arterial system. Varicose veins are varicosities that are dilated and tortuous. Men and women suffer equally from this disorder. The saphenous leg veins commonly are affected because they lack support from surrounding muscles. Varicose veins may also occur in other body parts, such as the rectum, called hemorrhoids, and esophagus, called esophageal varices. Varicose veins may be accompanied by a smaller variation called spider veins, which appear closer to the surface of the skin. Varicose veins have a familial tendency. The valves of the veins become incompetent in early adulthood, resulting in varicosities. In others, anything that constricts or interferes with venous return contributes to the formation of varicose veins. Prolonged standing compromises venous return as blood pools distally with gravity. Obesity and pressure on blood vessels from an enlarging fetus, liver, or abdominal tumor contribute to venous congestion. Thrombophlebitis may lead to varicose veins because the inflammatory process may damage vein valves. Normally, the action of leg muscles during movement and exercise aids venous return. When valves and veins become incompetent, blood accumulates rather than being propelled efficiently to the heart. The congestion in the veins stretches them. Over time, they cannot recoil and remain chronically distended. Venous hypertension then forces some fluid to move into the interstitial spaces of surrounding tissues. Venous congestion and local edema may diminish arterial blood flow, impairing cellular nutrition. Even minor skin or soft tissue injuries easily become infected and ulcerated. The healing of such lesions is slow and uncertain. Once the condition first manifests itself when other factors impair venous return. The legs feel heavy and tired, particularly after prolonged standing. The client may say that activity or elevation of the legs relieves the discomfort. The leg veins look distended and tortuous and can be seen under the skin as dark blue or purple, snake-like elevations. The feet, ankles, and legs may appear swollen. The skin may be slightly darker in the areas of impaired circulation. There may be signs of skin ulcerations and various staging of healing. Capillary refill may be abnormal. Diagnostic findings. The Brody-Trendelenburg test is performed for diagnostic purposes. The client lies flat and elevates the affected leg to empty the veins. A tourniquet is then applied to the upper thigh and the client is asked to stand. If blood flows from the upper part of the leg into the superficial veins when the tourniquet is released, the valves of the superficial veins are considered incompetent. Ultrasounds and venography are also used to detect impaired blood flow. Medical management. Treatment of mild varicose veins includes exercising, walking, swimming, losing weight, wearing elastic support stockings, and avoiding prolonged periods of sitting or standing. Defective smaller veins may be occluded using skin surface laser treatments. Deeper varicose veins may be sclerosed or occluded by injecting a chemical that sets up an inflammation in the vein wall. Endovascular radiofrequency, in which a catheter with a heated probe is inserted into the vein, is another alternative. Eventually, adhesions form and blood flow must find an alternate route through collateral veins. Surgical treatments for severe or multiple varicose veins consists of vein ligation with or without vein stripping. A vein ligation is a procedure which the affected veins are ligated or tied off above and below the area of incompetent valves, but the dysfunctional vein remains. For better results, the vein stripping is performed. In this procedure, the ligated veins are severed and removed. The entire great saphenous vein, which extends from the groin to the ankle, or the small saphenous vein, may be removed. Nursing management. The nurse assesses the skin, distal circulation, and peripheral edema, asking the client to rate the level of discomfort and ability to do active and isometric leg exercises. When a surgical approach is used, the client returns with a gauze dressing covered by elastic roller bandages on the operative leg. The nurse monitors for swelling in the operative leg and its effect on circulation. The nurse removes and rewraps the roller bandage to facilitate blood flow and inspects the dressing for signs of active bleeding. In the immediate postoperative period, the nurse elevates the foot of the bed to aid venous circulation to the heart and reminds the client to contract and relax the lower leg muscles. If active exercise is inadequate, the nurse consults with the physician about using pneumatic venous compression device stockings, which cover the leg from the foot to the thigh and periodically inflate and release air, simulating isometric muscle contractions. The nurse helps the client ambulate as soon as possible to promote venous circulation, reduce edema, and prevent venous thrombosis. When bleeding is no longer a problem, the nurse applies elastic anti-embolism stockings in place of the elastic roller bandage and provides adequate fluid to decrease potential thrombosis. When teaching the client and the family, the nurse identifies factors that impair venous circulation: wearing elastic girdles or tight belts, using round garters or rolling and twisting nylon stockings, standing or sitting for prolonged periods, and sitting with the knees crossed. The nurse describes appropriate foot and nail care to facilitate tissue integrity, explaining that any of the open areas on the feet or lower legs require examination and treatment by the physician. The nurse recommends active or isometric exercises and elevation of the extremities frequently during the day. The nurse demonstrates how to apply and remove elastic support stockings and refers the client to the dietitian if weight loss is indicated. Question. A client diagnosed with varicose veins is reluctant to have surgery to repair them. She asks the nurse what she can do to reduce the pain of the varicosities. The nurse suggests that the client, 1. Engage in 30 minutes of aerobic exercise every day, 2. Wear knee-high trouser socks, 3. Avoid sitting or standing for long periods, or D. Ride a stationary bike every day. The answer is avoid sitting or standing for long periods. The rationale is standing or sitting for long periods cause varicose veins to develop and increase the pain for the client. In addition, blood pooling or stasis predisposes the client to blood clots. Aerobic activity would increase the pain for the client. Occlusive disorders of peripheral blood vessels continues. Aneurysms. An aneurysm is stretching and bulging of an arterial wall. Aneurysms of the aorta, called in the aortic arch, thoracic or abdominal aortas, arteries, are the most common, but aneurysms can be found in other arteries, such as those in the legs and the brain. Arteriosclerosis, hypertension, trauma, or congenital weakness can affect the elasticity of the tunica media, which is the middle layer of the artery wall, causing part of the vessel to bulge. Once formed, some aneurysms lay down layers of clots, blocking the vessel until the blood flow stops. Most aneurysms enlarge until they rupture. Loss of a large volume of arterial blood leads to shock and death if not controlled. Some aneurysms tear and leak blood into surrounding cavities, such as the thorax or abdomen. Blood in a dissecting aneurysm is unavailable to arteries that branch off the aorta. When blood flow decreases or stops, the tissue death occurs. Signs and symptoms. Many aneurysms go unnoticed until found during physical exam of the client who has massive hemorrhage. Some cause pain, discomfort, and symptoms related to pressure on nearby structures. For example, a thoracic aortic aneurysm can cause bronchial obstruction. Dysphagia, which is difficulty swallowing, dysphagia is difficulty swallowing, and dyspnea. An abdominal aortic aneurysm can produce nausea and vomiting from pressure exerted on the intestines, or it may cause severe back pain from pressure on the vertebrae or spinal nerves. Most clients are hypertensive. A pulsating mass may be felt or even seen around the umbilicus or to the left of midline over the abdomen. A bruit, which is a purring or blowing sound, can be auscultated over the mass. Circulation to tissue may be impaired. Symptoms of a dissecting aneurysm may vary and depend on whether a branching artery has been occluded or a tear has occurred in the aortic wall. Many clients become suddenly and acutely ill. Difference in the blood pressures of the left and right arms may be marked, or the blood pressures of the left and right legs may be unequal. Severe pain and signs of shock usually are present, but symptoms can be less severe in some cases. Because symptoms vary, diagnosis may be difficult. Chest radiographs can demonstrate aneurysms when the arterial wall contains calcium deposits. Aortography identifies the size and exact location of the aneurysm. Medical and surgical management. Medical treatment includes administering antihypertensive drugs to keep the blood pressure within normal range. Aneurysms are treated surgically whenever possible. No other cure exists. They are repaired by bypass or replacement grafting. A dissecting or ruptured aneurysm is a surgical emergency. The nurse helps control hypertension by keeping activity and stress to a minimum. The client should avoid straining during bowel movements, coughing, and holding the breath while changing positions. The nurse monitors blood pressure, pulse, hourly urine output, skin color, level of consciousness, and characteristics of pain for signs of hemorrhage or dissection. He or she prepares the client for diagnostic testing and surgical interventions. Afterward, the nurse monitors for shock and adequate tissue perfusion. This is the end of the slideshow.